Okay, good morning, everyone. This is our training session that we're providing to our opioid treatment programs. It is brought to you by the state of New Hampshire Department of Health and Human Services. It's a joint presentation with our Bureau of Drug and Alcohol Services, the Bureau of Program Integrity at the department, and our Medicaid managed care organizations, which is WellSense, AmeriHealth, and New Hampshire Healthy Families. I will now lead over to Mike, who will start the presentation for us.
Good morning, everyone, and thank you for taking time out of your busy days to attend this very important training, that presentation that we're doing today. So, as you know, we have about, I would say about 10 or 12 of individuals here on the call from opiate treatment providers today. It's our hope and goal that we share this with all of the individuals that could not make the training. Today we'll be sending out a recording of this in the future. So please ensure that everyone in your organization up and down the chain of command gets to see this presentation, if not today, then in the future. I'd like to introduce our director for the Division of Program Quality and Integrity, Meredith Tellis, who will outline the important need for this presentation and training.
Thank you, Mike. Good morning, everyone. Thank you for joining us this morning. My name is Meredith Tellis. I am the Director for Program Quality and Integrity for the department. And we wanted to bring everyone together this morning because we had, as many states have had, an audit by the National Office of Inspector General, which found that medical records from you, our opioid treatment providers, did not have adequate documentation to support the claims that had been paid by Medicaid. So we followed up the state to do our own review. We asked our managed care organizations to follow up to confirm these findings. And we're not going to be discussing the specific findings today. The MCOs will organize individual meetings with each of the providers to have that discussion. Today, we wanted to go over more broadly the clinical standards and the documentation requirements that will help remedy the findings in the future. But I did want to highlight that this was not a small problem that was found. And we did, as I said, the state do our own review and confirm that it was an issue that occurred across all providers and at all of the locations reviewed. It's not exclusive to New Hampshire. There were similar audits done in other states with similar findings, but of course we care about New Hampshire. So we want to make sure the claims are well supported here. It's really not just red tape for the purpose of creating red tape either. As you're going to hear during the training, the documentation we're talking about exists so that we can be sure we are providing good quality care to the clients. And we're here today, and we know that you're here today because you're really invested in providing that high quality care. So this training is really an opportunity for us to get on the same page in terms of our expectations. And it's certainly an opportunity for you to ask questions. We encourage questions during this training. We'll be continuing to review records as time goes on, and we definitely want to see improvement over the next couple of weeks and into the future. So after this training, we absolutely expect and encourage an ongoing conversation and continued questions on what you're seeing on the ground, what you're experiencing, and if there are any specific obstacles to meeting the standards or to meeting the documentation requirements. We definitely want to hear about that because we want to be able to work with you, and our managed care organizations who are on the call are here to work with you on that going forward. We certainly want this to be successful. We want New Hampshire to be a leader in turning this around so that we can see that progress over the next few weeks and into the future. So I'm excited for this conversation this morning. I think I speak for all of the trainers on the call when I say we're looking forward to working with you on this. And with that, I will turn it back over to Mike, and he'll go over some housekeeping items before we get started.
Thank you, Director Tellis. That was very informative. So one thing we'd like you to do before we get started here is if our colleagues with the opiate treatment providers could just take a minute during this presentation and put your name and opiate treatment provider that you're representing into the chat. It's just another way that we can take attendance and know who's on the call. So sometime during this training, please take a moment to do that, and we appreciate it. A little bit of housekeeping here, the presentation guidelines. This presentation will be recorded and a slide deck. The recording will be made available to the attendees as well as a posting on the DHHS website. And you can just Google that if you don't know where it's at, and it will pop up. All attendees should mute their microphones. During each section, if there are any questions during the presentation, please record in the chat function or raise your hand feature can be used. You also can be directed by the moderator to remove your mute microphone to ask your question directly. And we have placed some strategic stop points after some of the presentation highlights. So there'll be a question and dialogue section there. And if you think of questions toward the end, we'll also be asking for questions before we wrap up. So, and as always, if you think of questions after the fact, there'll be a list of names of individuals doing this presentation today at the end of the slide deck, and you can reach out to anybody on that list also. Next slide, please. We do want you to know about the OTP provider requirements administrative rules listed here. All of these rules can be found online. If you have difficulty locating any of these, please reach out to me and I'll make sure I send them directly to you. 42 CFR Part 8, medication assisted treatment for opioid use disorders. New Hampshire Code of Administrative Rules. These are what we refer to as the HEA 304 rules. The certification and operational requirements for opioid treatment programs. And also the Part HEW 513, Substance Use Disorder Treatment and Recovery Support Services. Next slide, please. Our agenda today goes over 7 points. The first will be regulatory oversight and quality expectations that will be presented by the Bureau of Drug and Alcohol Services. Then we get into the meat, the ASAM requirements, screening, evaluations, treatment, and discharge/transfer quality expectations by our partners at WellSense. 3 will be the medical director expectations regarding medical exams, transfer documentation, take-home dosing, drug testing, counseling, and pregnancy. And this will be presented by our partners in AmeriHealth Caritas. Next slide, please. Section 4 will be staff qualifications, supervision requirements, licensing and screening requirements, and quality management, presented by New Hampshire Healthy Families. Documentation requirements for medical records will be presented by the Bureau of Program Quality here at the state of New Hampshire. Third-party liability billing requirements will be presented by our Bureau of Program Integrity here at the state of New Hampshire. And lastly, we'll be discussing waiver requests, and that will be presented by the Bureau of Drug and Alcohol Services. A lot of content, but very important content. So we hope that you find some real value in this presentation. Next slide, please. Regulatory oversight. So we're talking about our federal regulation, Title 42 CFR Part 8, the State Opiate Treatment Authority, and HEA 304 certification and operational requirements for OTPs. Next slide, please. HEA 304 does have quality expectations that you comply with all federal, state, and local laws, rules, codes, ordinances, licenses, permits, and approvals, and the rules of HEA 304.12 Part A. Also to monitor, assess, and improve as necessary the quality of care and services provided to clients on an ongoing basis, also covered in HE 304 Part 12C. Administrative remedies for violations of HE 304. We will require you to submit a plan of correction. We'll impose a plan of correction, and that will result in either the denial or revocation of certification. Next slide, please. Leading into our first managed care organization presentation, it'll be based on 42 CFR 8.12E and ASAM criteria. Next slide, please. And we are transitioning into our presentation by WellSense.
Good morning. I'm Kim Gordon. I am a licensed mental health clinician and MLADAC with Beacon. So the first topic we're going to cover today is screenings. When we say screenings, what do we mean? What's the difference between a screening and an evaluation? A screening tool looks for risks. It can be in the form of a short survey or questions that can determine if there's a problem. The advantage of a screening tool is that it's brief and can indicate if there is a need for an evaluation. During screenings, providers are looking to see whether the person seeking services meets the most basic requirements. Specifically for an opioid treatment program, outpatient level of care, that would be meeting criteria listed in the DSM-5 for an opioid use disorder, meeting ASAM criteria for an outpatient level of care, and of course, whether there is capacity at the specific site where they are seeking care to take them on as a client and offer the services most appropriate to match their needs. There are many screening and evaluation tools available for mental health and substance use disorders, and the tools can be general or specific by topic, population, and age. The most important factor in choosing any tool is to verify it's evidence-based and that it's been validated. A few commonly used screening tools are listed here on this slide. Screening tools offer important information as one piece of the clinical assessment. They can guide diagnostic insight, provide information on symptom severity, help inform treatment planning, and offer objective data. I think we're still on the screening slide. Sorry, I just saw you switch slides. So they can guide diagnostic insight, provide information on symptom severity, help inform treatment planning, and offer objective data by which to measure progress. Incorporating screening tools can also empower clients to feel that they're an active partner in their treatment and part of the collaborative process. After the screening tool is complete, it should be explained and discussed with the person seeking services, what it is measuring, how does it measure the specific concern, and how will this information play a role in their treatment. Completed screening tools should always be documented in the record and dated to note progress. While screening tools are a useful start to care, they do have some limitations. They do not indicate the cause of the identified risk or the issues experienced by the person, and screening tools should not be used alone for diagnosis. In the next slide, we'll look at evaluations. A thorough evaluation will dig deeper into the topics uncovered by the screening tool. So the appropriate screening tools are completed, discussed, and documented. It has been determined that the person seeking services is appropriate for this level of care. The next step would be to complete an evaluation. The evaluation should be conducted by a licensed clinician or a licensure candidate who has regular supervision by a qualified supervisor. The evaluation is where pieces of information gathered during the screening process can be expanded on. A few areas that are a staple in a good evaluation are confirming all diagnoses meet criteria. Risk screenings are completed specifically for those that have identified needs connected to HIV and AIDS. This is also the time for a medical exam to be completed. Ideally, an initial treatment plan will be written in collaboration with the client. An ASAM criteria is completed in detail, again, ideally with a written narrative to summarize the results. We'll take a look at ASAM criteria in the next couple of slides. All right, so moving on to ASAM requirements. ASAM is an abbreviation for the American Society of Addiction Medicine, which started in the 1950s, but did not develop what we know now as ASAM criteria until the early 1990s. Professionals working in any branch of substance use disorder treatment need to be proficient in appropriately using ASAM criteria. So what is ASAM criteria? A collection of standardized methods that result in information to guide providers to make an appropriate level of care placement. ASAM criteria also supports continued care, integrated care, and beneficial transfer through the treatment continuum. ASAM criteria consists of 6 dimensions, each with a severity rating. As you can see here, each of the 6 dimensions are highlighted and play a crucial role in the regulations for all SUD providers. Regulation HEA 304.16 states that specifics of how clinical services should be offered and that all services should be delivered using ASAM criteria. As we review the next few slides, it's important to remember that ASAM criteria is the foundation of all substance use disorder treatment. The information gathered by reviewing the 6 dimensions not only drives the level of care recommendation, but also guides the treatment plan, services rendered, transfer, and discharge from care. Okay, moving on to the next slide. We can see ways ASAM plays a significant role in treatment. Just to highlight a few, ASAM helps to ensure services provided are person-centered. So using the criteria as often as it's intended encourages providers to move away from fixed lengths of stay towards clinically driven interventions with expressed intention and evaluated results. We're all familiar with terms like 28-day program or knowing that phase 1 of an intensive outpatient program is 4 weeks long. However, ASAM guidance discourages fixed set of time and encourages providers to look at the needs of the person sitting in front of them and move through the continuum and levels of care as needed. The second point I'd like to highlight using ASAM criteria is that using ASAM criteria regularly helps providers stress that treatment outcomes are key. So repeated cycling through assessment, adjusting the plan, and adjusting the placement or interventions coincides with the previous point that the treatment should not be thought of as fixed, but flexible. We as providers should be regularly evaluating what our clients need and how we can best provide that, whether it be through services, referral, or coordination of care. And lastly, medical necessity looks at the whole person to make an intervention recommendation rather than emphasizing any one dimension. The information gathered in the 6 dimensions gives us a glimpse into the 6 major areas of our clients' lives. This is an opportunity to assess where there is need and see how we can help. Again, driving the treatment plan and coordination of care with a treatment team. Before we move on to the next topic, I just wanted to share some great resources on learning more about ASAM. So the official ASAM website is asam.org. Dr. David Mealy is considered an ASAM expert and has a lot of great information in his monthly newsletters. That can be found at davidmealy.com. And Beacon also has an ASAM training as well as many other trainings available on our website at beaconhealthoptions.com under the tab for providers. So moving on to treatment planning. The treatment plan is something we're all familiar with and have probably written many times. So let's just review a few basics. What is a treatment plan? A working and flexible document that includes objectives and measurable goals with clearly defined timeframes for achieving the stated goals and planned treatment interventions. A treatment plan should be completed at admission. If that's not possible, it should be completed at the first session following admission and updated no less frequently than every 4 sessions or every 4 weeks, whichever is less frequent. Treatment plans need to be updated simultaneously with any changes to ASAM criteria. All updates and changes to treatment plans should be amended to the original document. Do not replace the original treatment plan. It is important to see that updates and reviews are visible to track progress. The initial treatment plan and updates need to have the signature and date of the client, a treatment plan, provider, and treatment team signature, and the signature of the medical director. If any of these signatures are unavailable, document why that was the case. Updates should include documentation that the client continued to meet ASAM criteria at this current level of care. This is done by reviewing and updating the 6 dimensions, assessing their progress, current level of risk, and encourage the client to participate by adding their own words through quotations and I statements. In the next slide, we'll sharpen the focus a little bit and look at the foundations of treatment planning and a treatment plan example. So a few tips for quality treatment planning. Each part of the treatment plan should be in SMART goal format. SMART stands for specific, measurable, attainable, realistic, and timely. It should be clearly identified what the client's needs, strengths, and resources to complete their stated goals in the treatment plan. The treatment plan will define a strategy for providing services to meet goals, objectives, and interventions. Each part of the plan should be individualized. We want to avoid what's often referred to as cookie cutter statements. Ideally, if you look at a bunch of de-identified treatment plans from your caseload, there would be something specific about each one that you could identify which one of your clients it belongs to. Providers want to work together with clients to identify who is responsible for each piece of the plan. This helps both the client and the provider know how their role and how working together will assist in moving closer to accomplishing their stated objectives and goals. If a client identifies a problem or goal that requires intervention or services that can be provided by an outside resource, the expectation is the current provider will use their community connections and established referral pathways to accomplish this. The process for this would be to have the client sign a release of information and initiate contact on the client's behalf to coordinate care. Specifics as to how interventions and objectives will be accomplished and measured are important guidelines for the client to be aware of and should be stated clearly in the treatment plan. The documented goals should always be in the client's words, even if they are simple and brief. So looking at the example that we have up here, writing out a plan in SMART goal format takes a lot of practice and thought. One trick that has helped me is writing out each word represented in SMART. So again, specific, measurable, attainable, realistic, and timely, and then writing the goals in clients' quotes as they fall into each category as I've done here. This process can make it easier to put the appropriate information in the format we often see in treatment plans, which is goal, objective, and intervention. This is also a visual and hands-on way to collaborate with clients during treatment planning. Something to keep in mind is that there can be multiple objectives and interventions for one goal. So using myself as an example, we can see here that strengths and needs are stated in the client's words. Kim found out that she enjoys group therapy by completing an intensive outpatient program, which would be a strength. Her needs for transportation to make sure she attends appointments without, her need is for transportation to make sure she attends appointments without interruption. So obviously that would be a need. This treatment plan sets itself up to be reviewed after Kim has attended 4 group sessions. With an appointment already scheduled, it's a prompt for the provider to update the treatment plan during that session. In this case, if Kim reports she's enjoying group and feeling it's beneficial, the update might be minor changes, such as practicing coping skills she's identified with a specified amount of time stated until their next scheduled review. Even if the changes are small, they should be documented in the treatment plan, made collaboratively with the client, their treatment team, dated and signed by everyone involved. So the last topic that I'll be covering today will be discharge and transfer of care. There are several regulations that touch on the topic of discharge or transfer of care. Please take the time to know these specific regulations as well as the entire HEA 304 certification and operational requirements for opioid treatment programs. While aftercare planning might seem like it would come at the end of a treatment episode, it should start right in the beginning alongside treatment planning and be individualized to the client's needs. As with any contact and clinical services offered, aftercare planning should be documented in the medical record as it takes place. A treatment team is a valuable resource to a client's continued care and success in reaching their goals. An attempt to connect with all relevant sources of support should be made if consent is given. If a client cannot identify a provider and states they would like assistance in establishing one, it should become a priority to make every effort possible to make these connections prior to discharge. If a client does not want any communication between providers or declines assistance in finding providers, this should also be clearly documented in the record. Similarly, with legal guardians, family, or significant others, if consent was given, effort should be made to include the specified individuals in the client's treatment when appropriate and keep them updated on the aftercare plan, highlighting if there's any way they can lend support. Specific to opioid treatment programs, clients who are scheduled to discharge, leave ahead of planned discharge, or request to transfer care, all are required to have the option to participate in supervised withdrawal when medically appropriate. When a member transfers from one opioid treatment provider to another, the new provider should conduct a medical exam if the last one was completed longer than 3 months ago. All releases of information should be current with signatures so providers can communicate and share member records, including but not limited to progress notes, the last 3 drug screens, updated treatment plans, take-home dosing permissions, and any pertinent legal information. The discharge summary is a snapshot of the client's care with you as a provider. It should give a clear picture of what took place during their time with your organization and what the agreed upon plan was after the services end. Clients should meet with their provider for aftercare planning prior to discharge. Aftercare planning should include, at minimum, recommendations based on current ASAM criteria, include documented evidence that natural supports and community-based supports were identified and shared with the client, referrals to appropriate services, providers, and agencies, future appointments listed with providers, documentation that the member participated in aftercare planning or reasons why participation did not take place, dates of admission and discharge, complete history, summary of care and progress of goals, reason for discharge and transfer, current diagnosis, and any physical or medical conditions and documentation. The discharge plan should look like a list of accomplishments and/or needs from the treatment episode with you as their current provider, and a timeline of follow-up appointments along with specific resources with contact information for the client. This plan is documented evidence a path has been set for the client to transfer from your care into the care of another provider smoothly. Ideally, a discharge or transfer of care is an opportunity to develop a plan to help ensure the member is set up for success beyond the one provider. Identifying needs at admission and throughout treatment, positive referral pathways within the community, diligence with releases of information, and open communication between members and their treatment teams all assist in helping providers practice continuity and coordination of care. That concludes our segment this morning. Thank you for being here.
Sorry. This opens up our first opportunity for questions. And so if anybody has any questions at this time, please feel free to unmute and ask them or type them in the chat if you like. Not seeing any questions in the chat. We're going to have other opportunities to ask questions. We encourage you to do so. So, all the way through this presentation, if you think of something, we'll hit another question spot, or you can just raise your hand. I did notice a couple of late attendees from our opiate treatment providers. If you wouldn't mind, please, just putting your name and OTP represented to the chat. I certainly would appreciate that, and thank you for joining. Next up is our partners at AmeriHealth Caritas.
Good morning. My name is Iyad Al-Khoury. I'm a psychiatrist. Thank you, Michael. Thank you, Kim, for your presentation. Can everyone hear me, I'm assuming? Okay. So this section has to do with the role of medical director, including medical examination and transfer or requirement for documentation of transfer, take-home dosing, drug testing, and counseling, finally, pregnancy testing. Next slide, please. The following slides are not meant to replace the existing federal and state regulation. They're meant just to enhance our understanding of how we would like the actual treatment to be enhanced in the state of New Hampshire. The medical director expectations, there's in every medical or every treatment program, there is a designated medical director who is responsible for all medical services. And the medical director will ensure that rules and regulations are followed. And the medical director finally has to be familiar with the rules and regulation, including treatment plan updates, ongoing regular need evaluations. The medical director is the final responsibility or finally responsible for ensuring compliance with all applicable federal, state, and local laws and regulations. The medical exam or medical examination is required for every member entering the program, and it will have to be completely and fully documented before the admission to the OTP. And the only exception would be for those clients or patients who had been transferred. If the exam had been done or performed within the last 3 months, then it's not necessary to do a new exam. The exam has to be documented in the record within 30 days of admission. Next slide, please. Thank you. The requirement for transfer of client, it has to include a prior record or request for prior records after obtaining release of information. Those will include the clinical record, attendance, dosages, prior urine drug screens, medical information, discharge summary, and all relevant data. The take-home doses will have to be continued at the same level, but only after verifying compliance in previous program. Next slide, please. The take-home dosing requirements, as you see from the table, as the compliance increases in the program, then the take-home dosages are going to increase. Compliance is defined by negative drug screen and attending all required counseling. Those are the days you see in the table of the days of compliance are meant to indicate consecutive days of compliance, not simply how many days that the patient has been in the program. That this is a very important definition regarding compliance. Next slide, please. The take-home dosing will only be approved if the patient is meeting the criteria for compliance according to the table. And the medical director will make such a decision and will take in consideration several factors, including the negative urine drug screens, regular attendance of counseling and therapy, and the patient being stable overall and securable, and any other related data. At the end of the day, all of this has to do with the clinical judgment of the medical director that will have take the overall clinical picture in consideration. But those are very important factors. The take-home dosing will also indicate that there has to be counseling on safe transport at each eligibility change, and the ongoing approval must be documented at each progress review. If the pickup day is a holiday, then one extra take-home dose is approved, actually. And furthermore, if there is a flexibility or necessity for flexibility, then there has to be a submission of a waiver explaining why such flexibility is necessary. Next, please. Now, here's another table that indicates also the blanket exception that had been issued as of March 2020. And of course, that was related to the COVID epidemic. The requirement or the exception for the take-home dosages had to do with the maximum days of take-home dosages allowed, given the circumstances that took place in 2020. And for stable patients, this will include a maximum of 28 days of take-home doses. For those patients who are less stable, the maximum days are 14. Again, a reminder that this is a clinical judgment and has to do with the maximum days allowed, not minimum. It really depends on the clinical judgment of the medical director. Then in March of 2020, there was a further extension of that exception or blanket exception that might become permanent. It's still active right now. And the additional guidance here that have to do with stable and less stable patient has a lot to do with what Kim had pointed out earlier about ASAM placement criteria. If you look into those factors, they kind of overlap with ASAM dimensions, so to speak, except of course for the minimum days of treatment and adherence. But others have to do with the benefit versus risk, minimum days of negative drug screens, and the existence of serious behavioral problems. Another label for it will be another diagnosis of psychiatric condition, and a stable living and relationship. Also, the substance misuse related behavior, such as diversion or borrowing more of the drug, etc., and the safe storage of medications. Next, please. Now, regarding drug testing, the opioid treatment program must perform drug screens for every patient who is enrolled in the program. And the requirement for those will be at least one testing per week for the first 3 months of treatment. And after that, at least one testing per month for those members who are still in the program. And those are minimum requirement. Most of the time, the requirement, the actual clinical situation call actually for more than those frequency. And the programs are encouraged to actually use their judgment, given the circumstances and the overall clinical picture, to do more and more of drug testing rather than sticking with the minimum. The testing has to include the following substances: opiates, methadone, buprenorphine, which is also Suboxone, and amphetamines, cocaine, benzodiazepines, cannabis, and finally methamphetamine. It will be only considered positive if the substance that is tested positive in the drug screen is not actually prescribed by a licensed practitioner, and only considered positive if the client dispute the results and then further definitive testing is performed. For our state preference, we encourage the utilization of local labs for a better turnaround time and to improve our patients' outcome. Counseling hours, again, the table here shows actually the counseling hours requirement go down as the compliance goes up, which makes sense. But also included in the table, the allowed take-home doses to show also the opposite direction of the same concept. And compliance, of course, is negative urine drug screen and attending the counseling. And that's also defined by consecutive days of compliance, not the days that has been where the patient has been in the treatment. And as you can tell from the table, as the consecutive days of compliance increases, then the required counseling hours per month decrease, and the allowed take-home doses per week increase. The counseling has to do with, or it has to be based on individualized treatment plan, and it will include any combination of individual, group, or family substance use treatment services, and even case management up to 25% of the total number, including discussions regarding discontinuation of treatment. Group counseling has also some rules. It will have to be limited to 12 patients or fewer per counselor, and the number of clients and counselor information should be included in the record to support compliance. And all these documents have to be kept in the medical record of the patient. Next slide. And again, during the COVID, another factor that had played a role in the rules and regulation has to do with the introduction of telehealth. The Medicaid rule of coverage of telehealth had, of course, enhanced the services we offer in the state. Those, though, have some rules, and these are the following: that there has to be documented consent, written document signed by the member and the patient, and with the written consent of the patient receiving medication-assisted treatment through telehealth services provided under this section, the healthcare provider shall provide notification of the patient's medication-assisted treatment to the doorway on the website. This is again required by the rules within the region where the patient resides. The bill for the telehealth services will have to have the GT modifier and will include the place of service. There are certain platforms that are not allowed or permitted for such services for telehealth, such as Facebook Live, Twitch, and TikTok. The record will have to include the method of communication and as well as the reason for obtaining services through telehealth rather than in person. Pregnancy testing for all female clients of childbearing, there has to be a pregnancy testing on a monthly basis, unless there is a contraindication by sexual orientation or physiological factors, which would need to be documented to justify the lack of testing. If pregnancy is confirmed, then the patient is referred for prenatal care, and the further coordination with providers is going to be necessary. If there was a refusal of prenatal care, then the member has to sign the refusal and document that refusal to sign even in the medical record. The results of pregnancy status has to be entered on the WITS within 3 days of admission and discharge. Record should include all pregnancy tests and all the results. And that concludes the section regarding medical director drug testing and take-home dosages and pregnancy testing.
Thank you, Dr. Okari.
Thank you.
So we hit our second question spot. If anybody has any questions at this time, feel free to unmute yourself or type it in the chat at this time.
I have a question. This is Adrienne from the West Lebanon CTC. How would you like us to document if patients refuse a pregnancy test?
Oh, they will have to sign that they refuse the pregnancy testing.
Okay, and that will be acceptable by the state?
I believe so.
Okay, thank you.
Thank you for that question, Adrienne. Any other questions?
Me again, I guess I'm wondering about the counseling requirements for patients who are free of illicits for, let's say, 6 years in treatment. So technically they would fall on the lower end of the spectrum. However, they live in a state where recreational cannabis is legal. So you're saying we need to keep them at the 8 hours?
Yes, that's a requirement.
Cannabis still isn't legal in New Hampshire, so.
Correct. We are a border clinic though, so 2/3 of our patients are Vermonters.
Yes. But it's still, this is illegal for federal standard, yeah, and in New Hampshire.
Any other questions? Okay, can we go to the next slide, please? So our next presentation will be staff qualifications, supervision requirements, licensing, screening requirements, and quality management. And that will be presented by our partners over at New Hampshire Healthy Families.
Hey, good morning, everyone. My name is Andrea with New Hampshire Healthy Families, and I will be presenting this section on staff qualifications, supervision requirements, licensing requirements. The information that I will be presenting today is taken from the New Hampshire Administrative Code, Part HEA 304, the certification and operational requirements for opioid treatment programs. However, I am not presenting that administrative code in its entirety. I'm only hitting the highlights. So I would encourage everyone to read that code in its entirety so you're familiar with it. Next slide, please. The staff qualifications for specific duties. Personnel requirements. Their certificate holder opioid treatment program shall employ an administrator responsible for the day-to-day operations of the program. The opioid treatment program shall employ a medical director that meets the requirements set forth in HEA 304.23. The certificate holder is required to obtain and review a criminal records check from the New Hampshire Department of Safety for all applicants for employment, and that includes contractors, volunteers, and student interns. The only exception is those who are licensed by the New Hampshire Board of Nursing, and those requirements are pursuant to RSA 151(2). All staff, including contracted staff, volunteers, and student interns, shall meet the educational, experiential, and physical qualifications of the position as listed in their job description. All staff must be licensed, registered, or certified as required by state statute and as applicable. The opioid treatment program should not employ anyone who has been convicted of a felony, who has been convicted of or had a finding by the department or any administrative agency of a sexual assault, other violent crime, assault, fraud, theft, abuse, neglect, or exploitation. The program should not employ anyone who otherwise poses a threat to the health, safety, or well-being of clients. The certificate holder shall check the names of all applicants, including contractors, volunteers, and interns, against the Bureau of Elderly and Adult Services State Registry, maintained pursuant to RSA 161F49 and HEW 720, prior to employing, contracting with, or engaging them. If a candidate is listed on the BEAS state registry, the certificate holder shall not employ, contract with, or engage unless a waiver is granted by BEAS. The opioid treatment program shall meet the minimum staffing requirements. They must have at least one master's license alcohol and drug counselor or a licensed drug and alcohol counselor who also holds the licensed clinical supervisor credential. The program shall have sufficient staffing levels that are appropriate for the services provided and the number of clients served. The program shall have all unlicensed staff providing treatment, education, and/or recovery support services shall be under the direct supervision of a licensed supervisor. No licensed supervisor shall supervise more than 8 unlicensed staff. Unlicensed staff shall receive at least 1 hour of supervision for every 20 hours of direct client contact. Supervisions shall be provided on an individual or group basis or both, depending on the employee's need, experience, and skill level. Supervisors shall maintain a log of the supervision date, duration, content, and who was supervised by whom. Individuals shall receive supervision in accordance with the requirements set forth for the license held by that individual. Licensing and screening requirements. To be certified under HEA 304, an applicant shall have a current registration with the DEA in accordance with 21 CFR. The applicant shall have a pharmacy in compliance with RSA 318-51B and license in accordance with PH 600 as limited retail drug distributor as defined in RSA 318-1. Quality management. The opioid treatment program shall conduct a client record review of a minimum of 10% of the open client records on a quarterly basis. The opioid treatment program shall document the results of the review in a quarterly quality management report, including the number of records that were reviewed, a summary of the review results, a description of any deficiencies identified, the corrective action taken, an evaluation of the effectiveness of the corrective action taken, and a summary of any unmet service needs. The opioid treatment program shall retain the quarterly quality management report for 2 years and make them available to the department upon request. Any questions?
Hearing no questions, thank you, Andrea, for that wonderful presentation. We appreciate it. If you have no questions now, again, remember you can ask at the end if you're contemplating your thoughts. We're moving on to section 5, documentation requirements for medical records and provider enrollment. This will be presented by our colleagues here at the Bureau of Program Integrity.
Good morning, this is Karen Carlton. I am the current administrator for the Program Integrity Unit under the Bureau of Program Integrity. I'm going to discuss with you today the requirements of the documentation as set forth in the HEA 304.18, which is titled Client Record System Requirements. All documentation of elements of initial screening and evaluation is required in each member's record. Documented medical examination is also required as conducted in accordance with the 42 CFR Part 1, 8.12. The individual treatment plan, which you develop in the beginning of your sessions, either on the first session or shortly after the admission into the program, you need to have that as part of each member's record, as well as following the evaluation. And it should be reviewed no less frequently than every 4 sessions or every 4 weeks and updated based on any changes in the ASAM criteria. I point you to read the 304.23 I3. And I have an excerpt from that, which talks about treatment plan updates shall include. You need to document the degree to which the client is meeting treatment plan goals and objectives. You also need to have modification of existing goals or addition of new goals based on changes in the client's functioning relative to your ASAM criteria. And the treatment goals and objectives as follows should document the ASAM criteria that the member is currently in, as well as the domains and it's to be reviewed with the client, counselor, and licensed practitioner. And you agree upon the continued treatment at the current level of care, or the client requires treatment at a higher or lower level of care, and the updated treatment plan reflects transition to that level of care. The final component is the signature of the client and the counselor agreeing to the updated treatment plan or documenting the client's refusal to sign the treatment plan. It is very clear in the 304 what is needed in that individual treatment plan review, and that is evident in each member's record at the frequency as stated in the sentence. We also want to review documentation of all client services, including but not limited to progress notes detailing all medication and clinical services. The required hours of counseling per month according to consecutive days in compliance. Dr. Elkari already reviewed that with you. So if you need to refer to the table and HEA 304.24. Remember, it's compliance, not days of treatment. Any combination of individual, group, or family substance use disorder treatment services. Documentation of each session shall be in the client record system. I know this is a challenge when you have group therapy, but the suggestion is if you have a roster attendance, you need to black out the names of the other individuals that attended the group and put each one in each respective member record. That way it is the accounting for that group therapy. You also need an outline of each educational and group therapy session provided. And all group counseling sessions shall be limited to 12 clients or fewer per counselor. The final piece is a signature of the clinical staff. That will meet the requirements of the counseling. Allowed days, the supply of take-home doses per week. It should be documented in each member's record, all of the doses provided to the client in person and take-home. Exactly how many take-home doses were given. And I've seen at times they even do a count so that it's identified and the member also agrees if they are taking that amount of dosing with them. That concludes the requirements for the medical record. One last piece to that is you must keep your medical records in your offices and secure and available in case of an audit. The requirement at the state is 6 years for normal medical records. And I think there are some additional requirements for the safety of the sub member records. The next section I want to review is provider enrollment. All participating methadone clinic providers shall be a New Hampshire Medicaid provider. They have to be organized and operated independently from a hospital pursuant to the 42 CFR 440.90. They also have to be composed of licensed practitioners who meet the provider requirements for the particular medical service being performed. All service locations require a separate application. Meaning, if you open a new location, a separate application will have to be filed with New Hampshire Medicaid. If you close a location, a notification to New Hampshire Medicaid that you do not have that location any longer is done through our conduit partners at MMIS. You also must have a medical director, a master licensed alcohol and drug counselor, which is an MLADAC, and a licensed alcohol and drug counselor. To name a few, those are the individuals that must enroll and be affiliated to your group application for your site and or corporate office. Those are individual non-billing providers. The application is out on the portal and you can select that type of application and complete it right there on our MMIS portal. We will require an NPI from each of those individuals, as well as it will be a requirement on claims as they are the renderer for the services. If there are supervising capabilities that go on with the MLADAC and or the medical director, then those individuals would be the supervising renderer. So that you could put those on the claims. I'm sorry. Member care must be provided on an outpatient basis and under the supervision of a licensed physician affiliated with the clinic, which means that the physician is readily available to provide direction either by phone or in person. The physician has seen the member as a patient at least once and assesses the need for continuing care as necessary, and the physician assumes professional responsibility for the services provided to the member. I think Dr. Alkari reviewed that about the medical director being part of the team in making determinations about these individual members and their treatment. That concludes my presentation. Are there any questions?
Okay, hearing no questions, next slide, please. So section 6 is third-party liability billing requirements. This will be presented by our Bureau of Program Integrity. Tasha, please.
Hi, my name is Tasha Blanchard, and I'm the administrator for the Bureau of Program Integrity. Next slide, please. Today, we want to point out a change that occurred with Medicare in January of 2020. Medicare expanded their Part B coverage to include opioid treatment programs, including medication-assisted treatment, toxicology testing, and counseling as authorized under Section 2005 of the Substance Use Disorder Prevention and that promotes opioid recovery and treatment for Patients and Communities Act and implemented in the final rule, CMS 1715F. Next slide, please. So what does this mean for our OTP providers? What this means is if you have a client that is a dual, has Medicare and Medicaid coverage, you are now required to bill Medicare first for any services that are covered by Medicare. Medicaid is always the payer of last resort. Once you have billed Medicare for a service and Medicare pays for that service, Medicare will cross those claims over directly to either our managed care organization or fee-for-service, wherever the member receives their Medicaid, for final processing of that claim for any patient liability that may be outstanding based on Medicaid's allowables. If Medicare denies the claim, you will receive an explanation of benefits with Medicare's denial, and you will be required to submit that with any claim that you want processed through Medicaid. Next slide, please. Are there any questions on this change in Medicare rules?
Okay, next slide, please. Section 7 will be on waiver requests. Next slide, please. An OTP applicant or certificate holder may request a waiver of a specific provision of HEA 304.08 in writing from the department. No provision or procedure prescribed by statute shall be waived. Waivers shall not be transferable. A waiver shall be permanent unless the department specifically places a time limit on the waiver. When a certificate holder wishes to renew a non-permanent waiver beyond the approved period of time, the certificate holder shall apply for a new waiver with the renewal application or at least 60 days prior to the expiration of the existing waiver, as appropriate by submitting the information as a new waiver. Whenever you're putting in waivers, make sure you provide a solid justification for the alternative that you're suggesting. State of New Hampshire will definitely want to make sure that you meet the objective or the intent of the rule that you're trying to waive. We are certainly concerned that you do not negatively impact the health, safety, or well-being of clients, and that you do not negatively affect the quality of the services provided by the opiate treatment provider. So please keep that in mind when you submit your waivers. Next slide, please. Opiate treatment programs are regulated by 2 federal agencies, the Substance Abuse Mental Health Services Administration, we know that as SAMHSA, and the Drug Enforcement Administration, the DEA. As an agency within the U.S. Department of Health and Human Services, SAMHSA regulates the public health aspects of OTP operations, specifically under 42 CFR Part 8, which we opened with. SAMHSA has administrative responsibility and oversight for treatment delivered by these programs. To be certified by SAMHSA, an OTP must be accredited by a CSAT-approved accrediting body like CARF, Commission on Accreditation of Rehabilitation Facilities. CARF accredits the majority of OTPs in the United States, but not all of them. DEA, as an agency within the U.S. Department of Justice, is responsible for program security, including medication storage, record keeping, and dispensing. Under the Controlled Substances Act, the DEA has primary responsibility for regulating the use of controlled substances for legitimate medical, scientific, research, and industrial purposes, and for preventing these substances from being diverted for illegal purposes. DEA regulations are documented in 21 CFR, parts 1300 to end. In addition, OTPs are subject to the state regulations, including the HEA 304 rules, which we have gone over pretty thoroughly today. For a discussion of DEA regulations for opiate treatment providers, please see Narcotic Treatment Program, a guide to DEA Narcotic Treatment Program regulations, seen and available here. Next slide, please. These next 3 sites will be contacts from our presenters today, whom we thank very, very much for their expertise and work they have provided to make this presentation today. Next slide, please. And next slide, please. So all of these contacts will be on our on the presentation that you've received. And please feel free to reach out to any one of these individuals if need be. This concludes our presentation and training today. We're gonna, in a second, we're going to do final questions and some input from anybody who wants to wrap some things up. I'd just like to thank you as the State Opiate Treatment Authority in the state of New Hampshire. I'd like to thank you for coming today and taking part in this training. As you can see, a wide continuum of individuals has put forth their expertise to bring this training to you. It's our goal that you share this with all of your colleagues up and down the chain of command, and also to realize that the reason we're here today. And the reason we're here today is because the Office of Inspector General found deficiencies. And we need to make a change here in the state of New Hampshire to meet those deficiencies. Everywhere throughout the presentation, I saw the word documentation, documentation, documentation. So in order to get credit for providing a service, you first have to provide the service, and you have to document that within the confines of everything that we just covered. We'll have other audits coming. We'll have follow through, and it is our hope that we work collaboratively together to reach a positive outcome. So we want you to succeed. We want you to meet the expectations that are in rules and statute and law. And we know you can do it, but we're here to be your partner. So we certainly hope that you utilize these trainings and any future communications to reach those goals. And on that, I open it up to anybody else who'd like to either ask a question or make a comment. Anybody? Any feedback if you found this to be helpful? Sarah or Carla or Vlad, anybody out there want to comment on the training?
You're going to name drop us like that, huh, Mike?
Yep.
Yeah, I mean, the training is useful. It's good to review the rules. I know we all spend a fair amount of our time in HEA 304. It's also good to review the regulations versus what we may have developed as best practice or as practice based on staffing shortages or whatever we've had through the COVID-19 pandemic here. Everybody, of course, understands the regulations didn't change, but a lot of things did change for us in the last 2.5 years. So yeah, I think it's useful training. It's certainly always good feedback. It's nice to return for a look to the regs.
Thank you, Vlad. Carla?
Yeah. Mike, yeah, absolutely. I would agree. Just to review again is always good, and where we've had such staffing shortages and with COVID, just reviewing and making sure that the staff is thoroughly trained to go forward.
Thank you, Carla. Anyone else?
Can I just throw out, I'm just curious, do folks think this is something they would use for new staff training if the recording's available?
I think that would be very helpful.
Yeah, I think it would be useful, especially in training center leadership. I don't know if every new hire it would be appropriate, but it would certainly be a nice resource to have available.
Yep, okay.
Great question. Anybody else? Well, we want to thank you for joining today. You can anticipate in the future to have a document coming to you with an FAQ and also highlighting the URL that will show you where the training recording can be located. We also really want you to take this back to your management, to your medical directors, to your staff, and have a discussion. Knowing that we're coming in from the state, knowing we're coming in from the MCOs, knowing that there will be other audits. We don't want this to be a negative, but rather a positive. So anything we can do to help facilitate you reaching a positive outcome, we want to hear. And if there's any way we can help, we will within the confines of the rules and laws associated. So with that, I thank you all for joining, and again, give thanks up and down the rows for everyone who worked so hard on this presentation.
Thank you, everyone. Have a good day.
Thank you.
Thanks, everyone.
Thank you.